For my medical colleagues out there, there are a number of you that have more technical questions regarding what we do here at Total Pain Solutions and what our approach is, what's the rationale, what's the technical component behind the things that we do and why we do it. Now, we all know the classic teaching about postherpetic neuralgia that we were taught in medical school. So somebody gets chickenpox, and then after the chickenpox resolves, the virus lies dormant in one of the dorsal root ganglia. As a result of that, when the patient develops shingles, which is reactivation of that virus along the pathway of that spinal nerve or cranial nerve in some patients, the rash appears along the course of that particular nerve. The pain that patients have and the other symptoms, including itching, burning, and the other symptoms that they typically have, also follow that same pathway. That's the classical teaching. And as a result of that, most of the historical approaches to postherpetic neuralgia have been focused on treating the problem near or at the dorsal root ganglion, because the assumption has always been that because the virus lives in the dorsal root ganglion, that's where the problem is, and that's where the pain is arising from. There was a study that was published a number of years ago. It's one that I would love to duplicate or replicate. If there's a pathologist out there that would be willing to work with us on a research project. They looked at patients who had postherpetic neuralgia of the chest, okay? And they compared skin from the affected side to the identical skin on the unaffected side. When you looked at it under the microscope, under histological analysis, turns out there were changes in the skin that occurred in those patients. Specifically, there were changes in nociceptors on the side where the patient had postherpetic neuralgia as compared to the other side. And the patients had more nociceptors on the side where they had postherpetic neuralgia as opposed to the side that did not have postherpetic neuralgia, which suggests that there are changes that occur at the skin level as a result of the postherpetic neuralgia. And the preliminary analysis of the data that we've looked at so far shows that we have results which are comparable to or superior to the results that you get with stimulators, that you get with radiofrequency ablation and other techniques like that. If the problem is actually not at the dorsal root ganglion, and the problem is at the skin or at the junction between the neuron and the skin, then it would make sense that shutting off that signal from the pain generator, if you want to think of it that way, would be the way to eliminate the pain, right? But this patient came to me and said, I have postherpetic neuralgia, I want you to do something about it. And I explained to him the classic teaching about postherpetic neuralgia and that there was nothing that I could. I went on to tell him, look, I can do a neurectomy, but I don't think the neurectomy is going to help you because that's not where the problem is. The problem isn't in the peripheral nerve, it's not distal. The problem is proximal, and I can't get to that. How about this? I'll simulate the results of the surgery that I know how to do by doing a nerve block. In this case, it was an intercostal nerve block. I said, I'll prove to you that surgery isn't going to help. I'll do the intercostal nerve block, which I did here laterally. So it wasn't anywhere near the dorsal root ganglion, right? And his pain was here on the front of his chest. I said, okay, let's repeat the block because it's doubtful that if the results that you got from the previous block were due to a placebo effect, it's less likely that you'll have that 2 times in a row. So we repeated the injection and he got the same result. his pain was gone. Of course, I thought to myself, well, I guess it's better to be lucky than good. And sure enough, he sent one of his friends to see me who also had postherpetic neuralgia, and I did the same thing for her. We did the 2 injections, and then we did the surgery, and she's been pain-free ever since. And that's what led me to wonder, well, maybe our understanding of postherpetic neuralgia, the mechanism of postherpetic neuralgia, is incomplete. And so we routinely started doing peripheral nerve blocks for these patients on the affected nerves, if we could identify the appropriate pattern. And sure enough, a lot of these patients, not all of them, but a lot of these patients ended up with some pretty significant release temporarily from the blocks. And I said, well, I can duplicate that result permanently with a neurectomy. And they said, let's do it. So that's been our approach to postherpetic neuralgia. If you've got other questions about it, you want to talk specifically about how we do this or why we do this, or the data that we're using to support this, then please feel free to reach out to us. I'm happy to chat with any of you about more technical details of our approach to postherpetic neuralgia. Patients apparently call this the suicide disease, and there's a significant number of patients who ultimately choose to commit suicide rather than deal with the pain. If we can help save some of those patients from that fate, I'd like to be able to do so, and I can do that with your help.